Hi, everyone. Welcome to the Evolution of Diabetes Policy. How did we get here? Um, we have Jake Johnston and Tom Boyer with us today. Jake and Tom are two front runners in the diabetes policy space. They've worked in it all their lives, and they're pretty much your go-to people for anything diabetes, anything policy, and anything diabetes policy. You may have seen them on a brown bag before, and we brought them back because, according to your lovely feedback, they're awesome and we love hearing from them. How does that make you guys feel?
Surprised.
Very surprised. And I'm going to record that and put it on repeat in my kids'
It's
Exactly.
room.
already, it's being recorded. It's going to the cloud and Facebook.
Perfect. I'm going to put it in my kids' room. It's going to be the first thing they hear every morning. So thank
Thank
you.
For those of you in attending this, for to get a compliment like that from Amanda to the two of us, you have to understand how singularly exclusive this is. We're going to hang on to this day.
Don't get it twisted. I didn't compliment you. I said the people liked you. I didn't say
I'm going to
anything.
hear it how I heard it, Amanda.
Okay. Well, we're happy to have you guys again, me included. So thank you for joining us. And I guess I'll just go get right into it. Let me stop sharing my screen. Uh, okay. So if you keep up with diabetes policy, it maybe feels like we've had more than one "this is the most consequential time in history" moments. So Tom and Jake, when you zoom out over the last few decades, what stands out to you as some of the actual most consequential shifts in diabetes policy and why?
Well, I'll take it first, and then Tom can back clean up on this one. I think that really there are two fundamental things that happened in diabetes policy, and we don't really have the ability to see who's in the attendee list right now. But if you were alive in 1989, you did not have any legal protection for employment or healthcare because of your status as a person living with diabetes. That changed in 1990 as a result of the Americans with Disabilities Act. And then again, we had the right to health insurance coverage as a part of the Affordable Care Act in 2010. So those are the two things directly relating to your question, Amanda. I think that those two things are the absolute underpinning of all of the other things that we're working on today from a policy standpoint. Tom?
Yeah, and Jake and I, documenting our advanced age, actually lobbied on the Americans with Disabilities Act back in starting in 87, 88, 89. Sound about right, Jake?
Yes, I was
Yeah.
4.
You were 4. I was 2. So even better. Couldn't even walk yet. I was a little bit older than that. But that's a pretty good summary. I actually suggest that now is arguably a more consequential time
Yep.
because of the speed with which these rights are being eroded in some pretty consequential ways. The current Justice Department announced yesterday or the day before that they are seeking some fundamental rewrites and reframing. This was in conjunction with the Department of Labor to the employment rights that are available to people, suggesting that the pendulum had swung too far in the direction of protecting workers as opposed to protecting employers. I'm not sure that's the case, having recently visited the European Union, which has some pretty consequential worker protections in place in comparison to the United States. I'm not sure that the protections had gone far enough, but I know this: if they get eroded at the speed with which I'm seeing them eroded right now, that being worker protections and also health insurance protections, there's not going to be much left before long. And that concerns me in a pretty consequential way.
Yeah, so we'll get more into what's going on today later in our webinar, but I wanted to ask a follow-up question to what you mentioned about the ADA and the Affordable Care Act. And can you tell us about, for the younger members of the audience, what the experience would be like to live before and after those consequences shifts?
Yeah. So again, like I said, we passed the Americans with Disabilities Act in 1990, and so prior to that, any employer could choose not to hire you just simply because you had type 1 diabetes. And beyond that, even if they did hire you, they could certainly hold you not have to make any accommodations for you in the course of working for your job. And when I graduated from college, one of the things that I really had to think about was what type of jobs were available to me as someone who needed, health insurance and needed access to a workplace that would allow me to take care of myself. I've been living with type 1 diabetes since 1974, and it's there are things that you simply have to do. That law, and I want to be clear, I don't consider myself disabled, and I don't think most people living with type 1 diabetes identify with as a disability in terms of what we do. But that law, the Americans with Disabilities Act, created a legal foundation for the types of protections that we have today. And it set the stage within 15 years following that act for people with type 1 diabetes to become pilots, to become long distance truck drivers, and the rest of the essentially employment opportunities that had been previously closed to us. So from my standpoint, 1990 is not that far ago, but at the same time, it really set this entire legal framework for the types of rights and responsibilities that we enjoy today and that we depend on today. That didn't touch healthcare, though, which is where the Affordable Care Act comes in. And I'll pass it to Tom for that one.
Yeah, I mean, Jake's absolutely right. It truly, if you needed an accommodation, it came down to, were you working for someone that was willing to give you the accommodation?
Yep.
And I even go so far as to say school, college, public schools, you name it, it was a negotiation with the person, which it still is, but you didn't have this framework to fall back on. As an example of what I said about the European Union, in France, it is specified in statute that type 1 diabetics, type 2 diabetics, anyone with an underlying metabolic condition has certain protections afforded to them in statute. The Americans with Disabilities Act, does not go that far, does not get that specific, but the courts have interpreted it to be that specific, which I would suggest is a good thing, not a bad thing. But these things are starting to get eroded. Also, there's been a shift in how government affairs and how citizens kind of interact with legislatures and also administrators, that'd be regulators, from the time that I started doing this. And I've seen these little shifts happen. And it was really apparent during the Affordable Care Act, where I could really start to see this consequential shift. And that would mean that the accessibility was more afforded to people that had big lobbying teams and big campaign contribution budgets and things of that nature. And I think it's become even more pronounced since then. There were some things that happened September 11th, the attacks on the country, that I think accelerated some of that accessibility issue, but it's now ingrained in the system, which is why I keep coming back to why I think today is more consequential, because it's imperative that the disease community, get its footing so that it can actually ensure that its voice is heard. Yeah. And the example that I use for that, it's the disagreement over subsidies and whether or not we want health insurance to be affordable in this country. The speed with which that happened and the silence with which it's occurring is of concern to me. The consequential shifts that have happened to Medicaid. And I'm seeing it in even simple things like the relaxing of directives for nursing homes and long-term care facilities, that they don't need to have the same staffing model that was dictated about 3 or 4 years ago. That creates challenges for people with diabetes who are really, really disabled, wheelchair bound, need home assistance and whatnot. Having accessibility to caregivers, it becomes really complicated. But the changes in the Affordable Care Act, that was a good decade and a half to 2 decades of work, ensuring that states were obligating that diabetes needs would be covered by private health insurance and also Medicaid. so that when there was this massive effort at the federal level, which really to describe that it's a massive effort, it's a program that affects about 60 to 70 million Americans, some other underlying changes in Medicare and Medicaid that made it more far reaching, but it really affects 60 million Americans that have no other place to go to get health insurance. And we, because of all that legwork that we had done in the States, it made that change a lot easier to make diabetes needs essentially defined as an essential health benefit.
Thank you. So I know you guys kind of touched on this when I was asking you to elaborate about before and after these two consequential shifts, but were there any specific moments in early diabetes policy where certain exclusions or discrimination was considered normal or acceptable that would feel shocking to young people with diabetes today?
Oh yeah, lots. Uh, let's see. There were no active military officers in the United States military with type 1 diabetes. That's fact. That changed during Operation Desert Storm, where for the first time there were people with type 1 diabetes allowed to go out and do their job in some pretty intense areas of focus. Snipers, people who would be out in the desert for months on end. That would not have been afforded ahead of time. We did not have any commercial pilot designations. You could not drive a truck or bus interstate, be engaged in interstate commerce. There are a lot of cases with the FBI where people would not be allowed to carry weapons or even serve in the FBI as somebody with type 1 diabetes if you were using insulin being the trigger. Some of these restrictions still exist, but not in the amount that they once existed. There were certain private employers, I don't want to name them by name, but engaged in overnight shipping that would not allow people with type 1 diabetes to drive a forklift. And there's a lot of case law on this matter now looking at these issues. But I get concerned when I see the Office of Civil Rights at the Department of Justice being decimated, and the Office of Civil Rights and all of these agencies like HHS, Department of Labor, Department of Education, when I see their staff being decimated by things like the efficiency programs and whatnot that this administration's been running, that has a detrimental impact on people with diabetes. So to think that all of these hard-won victories could be gone with the waving of a magic wand, that's scary. That concerns me.
I have one more thing to add. This protection that we have, right? Living with diabetes and being in the world. I think one of the things that people are most surprised about is that if you are a parent of a kid with type 1, or if you went to school as a type 1 kid in the last 20, 25 years, and if you were able to do that easily, that is kind of a newfound set of laws that exist at the state and the federal level. And prior to states, or prior to the federal government creating, accommodations for people with diabetes, and then prior to states taking that on and figuring out how to make that work within individual states, kids would be excluded from school activities. And that means can't go on field trips if you're in elementary school because there's nobody there who can provide medical care if you're going to the zoo or the science center or something. That means denying kids the ability to play sports in a public school situation. That means also requiring families to send kids in a school district to a school that had enough medical resources in place. And this allowed school districts to basically take kids away from their neighborhood schools and direct them to certain locations. This was just commonplace. This is what we did with limited resources and how schools wanted to handle this problem. That all changed because of this fundamental foundation of laws that allows kids to administer insulin if they have the ability to do so in a classroom setting, and to not be excluded from other types of school activities and things. I'm not a staffer with any diabetes organization. I'm just a volunteer. I live in Seattle, Washington. And like the number one thing that people living with type 1 talk to me about in terms of the day-to-day activities is actually school and job. And how, well, and the cost of healthcare, but that's maybe that one is a totally different one. But just how do I make sure that kids get what they need in these types of equitable environments?
Yeah, and that shift happened, that was in 1989.
Well, 1990 created the legal foundation, and then states started looking at, well, what does this mean? And so different states went first, and different states went faster, and some states opposed it. But out here in Washington State, for example, in the mid 90s is when we finally started getting the rights for kids to have to not have to leave the classroom in order to take care of medical needs. So if you had a low blood sugar or needed to use the bathroom or needed to test your blood sugar or take insulin. Prior to this, the kids would be required to leave the classroom, go to the nurse's office, and then wait for essentially medically trained assistants in order to be able to do those things. And we created a law here in the state of Washington, similar to what happens in a lot of other places, that allows either other non-medically trained adults to be designated to assist in that role. So a teacher, a coach, a bus driver, whoever it may be, or for the kids and the parents to have the control over that dynamic. And it's game changing for kids. It's just it diminishes an exclusionary lifestyle when you're in school.
Yeah,
But
absolutely.
to Jake's point, I wanted and to keep coming back to this theme of how quickly protections can be eroded. About 15 years, there was an effort to repeal that law in Washington State.
Mm-hmm.
And yesterday, there was an effort in Indiana to repeal its law. So the main reason that states started to get on board with these efforts is that it had to do with the threat of lawsuits, the threat of litigation. And there were a number of states that decided that they wanted to fight the Americans with Disabilities Act, and they lost before some real hyper conservative justices who viewed this as an individual rights issue and decided it was imperative to plant the flag and protect the civil rights of people with needs. So these things can go away very quickly, very quickly.
Yeah, thank you for mentioning the Indiana yesterday. So moving diabetes policy forward seems like a combination of many different moving parts, data and evidence, patient stories, political context, and timing. How do these forces interact?
Imperfectly with chaos. I mean, you're absolutely right, Amanda. Like there's an undefined miasma of things that have to happen for policy to get changed, right? And I don't know that any of us know the secret sauce. Maybe Tom does because he's really smart. But there we know that one of the ingredients that has to be in the mix is an activated patient voice. If you don't have people demanding something to happen, it does not get done. Legislation, whether at the state level or the federal level, is designed to be hard to pass. That's why governments are set up in that way to make legislative bodies responsive to a slower time arc. And the only way that you break through that is to create enough people asking for it. So I think that of all those things that are true and all those ingredients that are part of successful changes in policy, one of the key ingredients is frankly, having an army behind you.
Yeah. And Army, let me emphasize this to be of consequence. I take my hat off to anybody that's engaged in public service these days. We've had serious threats in a number of states to elected officials, one as recently as last night. It's important for everyone to kind of keep their wits about them and be respectful about this process that's been ingrained, because it's been ingrained in the very fabric of this country, because our accessibility to these elected officials is being curtailed more and more and more, some cases rightly so. But it's imperative to engage in a respectful, diplomatic, and appropriate way. And that's why organizations like ours are here. I want it's really important that our community continues to have access to these elected officials. And I'm not saying play nice. What I'm saying is play respectfully and make your voice heard in an effective way, not in a way that disintegrates the process and denigrates the process. I think that's even more important. I've recently been around a number of legislators that have been targeted, and it's a real scary, sobering moment to be in that presence.
Tom, I don't disagree, but I would push back a little bit. I think that is the role of diabetes organizations like DPAC to be to engage in the realm of what is possible to change and how to change it, and to do so with diplomacy and sophistication and, frankly, the engine to get it done. But I think that there is an equal role for individual members of the chronic disease community to appear, not in a violent way, not in a hostile way, but to create an accountability matrix for elected officials. For years, the House of Representatives voted more than 70 times to try to repeal the Affordable Care Act. And every time, I'm over exaggerating a little bit, but the response of us in the chronic disease community every time was to be like, oh, good, they didn't do it. Thank goodness, we'll just be quiet over here for a minute. And then they did it again, and they did it again, and they did it again. And the missing ingredient from my standpoint were individual people going to town halls and just asking an accountable question of their elected officials. Why don't I deserve access to health insurance? Explain that to me.
Oh, we're on the same page.
Like,
Yeah.
but that is not the approach that organizations that are involved in advocacy movements can do. That is the exclusive control of individuals that are engaged in these types of activities and responses. But both are important. And frankly, we let everybody who's against us off the hook. That's on us.
Absolutely fair. We're on the same page.
Okay.
Yeah. I want to hold everybody accountable.
So how have changes in federal policy impacted what states are doing and vice versa? And what should we keep an eye on in the next year or two?
You want to go first, Tom?
Oh boy. I'm going to be frank, and unfortunately, it may be a sobering assessment when it comes to healthcare policy. All change is local at the moment. And we're about to see a situation where there are going to be have and have not states. What I mean by that is a state like California may provide tax incentives and subsidies to enroll so that people can afford the health insurance available through the California exchange. Well, that's great for people in California. What are you going to do if you live in Texas, which doesn't have an exchange, which obligates you to go through the federal exchange? I mean, really, good luck. Same starts to play out in Florida. Same starts to play out in Alabama. Same starts to play out in Mississippi. I don't get as concerned about Massachusetts and New York residents and New Jersey residents. But the biggest impact of type 2 diabetes is in these quote unquote have not states. And I don't necessarily enjoy being in the position when in front of a group and talking about health insurance reform and what it means, and someone raises their hand and said, oh, I can't get health insurance in my state. Oh, what state do you live in? And they name a state that's affected. And I say, unfortunately, the best advice I can give you, move. And that's the reality. It's going to be state driven. There are very few opportunities at the federal level to affect change because they're really only going to be 2 or 3 bills that will be must pass, where things like health insurance provisions or Medicare provisions or Medicaid provisions can be attached to them. And then we're going to see the same matters play out on the civil rights side. There are going to be few opportunities at the federal level, which then pushes things to the states, which have a very compressed calendar, and things are happening right now. That's unfortunately what I see out there right now. It's going to be a lot of state-driven activity.
I agree that the actions in the states in the short term, I would just advise everybody that, the federal and state dynamic is a push-pull dynamic. So the feds do something and the states respond, or the states start to innovate and do different things and it forces a federal response. What I would say is happening out of the federal government right now is twofold. One is that the changes that they are making to the Medicare program, and maybe I don't know who on this webinar is insured by Medicare, but why that's important is that that is exclusively the purview of the federal government. And because it's the largest insurance program, it tends to dictate what other private insurance covers. So as the federal government makes changes that are almost always connected to the cost of things, that creates a permission structure for private insurance companies to do the same. So at the federal level right now, one of the threats that we're facing is the Medicare program determining kind of how does your insulin pump get covered and what type of insulin pump you're allowed to get and what is the ownership of that pump between you versus the insurance company, meaning the federal government. All of those things maybe seem weird, but it's going to actually impact everybody no matter how you're insured. The other thing that happened at the federal level, of course, is last year's HR 1 created, almost $1 trillion in cuts to Medicaid programs. And that is going to require states to respond to that impact on people that are insured through the Medicaid programs in their states. And some states, like Tom was talking about, aren't going to do much to ensure their populations against this. Some states are going to find the resources to do so. It does create an inequality between people's healthcare depending on where you live. That is the challenge before us in the next decade, Tom. I don't know, maybe forever, but that's the big challenge between us.
It's incredibly difficult to bring change to the benefit of people. I'm shocked by how easy it is to bring about change that is detrimental to people. And when I say people, I mean our people affected by diabetes. That's on full display for everybody at the moment. And these changes that start in 20 really have to start to happen in 2026, so they don't officially happen until January of 2027. People are going to see a lot of changes in how they obtain healthcare in their local areas.
Hey, real quick, Amanda, I see there's a couple of questions in the Q&A. Are you going to handle that as our moderator, or do you want us to?
Sorry. Yes, I will handle it.
Very tech savvy, Mr. Johnston. I, on the other hand, am just
us youngsters, Tom.
Yes, we can take a break from our questions, and it's okay. I'm seeing, have there been any conditions removed from the Americans with Disabilities Act beyond the erosion of protections?
not that I'm aware of. That said, the Americans with Disabilities Act is only as good as the legal counsel that one has afforded to them. So the erosions that are happening or could occur are occurring in individual case by individual case basis. So I'm going to use an example. Age-based discrimination is one of the first places that we're seeing a lot of latitude provided to employers. So a lot of employers are saying, just as an example, it used to be over the age of 50 that someone couldn't discriminate against you, but it's lowered to 40, which is creating a whole bunch of sand that can be thrown in the proverbial gears of the justice system. And it just clouds the perspective of, well, what is age-based discrimination? So while something may be a diabetes-related discrimination activity, once you throw in age-based discrimination, it becomes more difficult to argue the point, which again leads to how good is the legal counsel that you have representing you. So
I actually have another one, which is that the direct answer to your question, Rocky, is no. We have not removed any legal protections from the Americans with Disabilities Act as of yet. That being said, this administration is issuing executive orders that are trying to make all federal funding restricted to entities that do not have, call it diversity, equity, inclusion, but that also includes accessibility. So if you are a recipient of federal funding, and that's usually cities and hospitals and everybody else, And you have policies in place that are designed to accommodate a workforce or a community or everybody, and that is a value that you have, you may have to forego federal funding in order to have that grant agreement executed. That is all being adjudicated right now. That's all in the courts. We don't know what the outcome of it is right now. But I would say it's actually super scary because the question is, can the president unilaterally undermine the law? I mean, that is really what we come down to.
Yeah, sorry. I was also looking at Mike's question. Would you suggest having a scorecard for legislators? Mike, could you tell us in another question what kind of scorecard you mean by that? Um, Unless Jake, you had an idea.
You mean who's with us and who's against us? I love that idea. It's really hard to do. We have Tom's a veteran of kind of diabetes advocacy at a professional level for the better part of his career. He could probably answer because this is an ongoing conversation where we go back and forth on it a little bit and like is it a good thing or a bad thing to have? Um, Jake Johnston, the volunteer sitting out in the wilds of Seattle, says, heck yeah, I'd love to know which of my members of Congress are my friends and which one are actively working against me. But Tom?
It's kind of it's difficult to create these absolutes because one day a legislator is on your side or a regulator is on your side, and the next day you are at odds with them over an example in California that's a few years old at this point. Kids' ability to get care during public school hours from any willing layperson. And Governor Newsom's administration at times has been on the other side of that issue. And Governor Newsom's administration is doing a lot of things to protect people in health insurance programs. So I use the Governor Newsom example it's kind of a loaded argument, but to bring the point home, one day that legislator is out there saying, I got 100% from DPAC and DLC. Am I or am I not great? And then the next day they're doing something to undermine a provision that's of great import to the community. So it's a complicated thing to do. On some issues, it's very easy to do. On something as complex as the issues that we're dealing with, it's tough. It's tough to do.
Thank you. And going back to our programming, I wanted to ask, can you walk us through a moment where advocacy clearly changed the outcome of a policy decision? Perhaps on a lighter note from the doom and gloom we've been discussing.
Yeah, I've got one from the state of Washington, and then I know there's a million stories out of frankly the Affordable Care Act as well back in DC. But out here in Washington State, back before CGMs existed, the state of Washington, in its infinite wisdom, decided that the state Medicaid program would only reimburse for one blood glucose test strip per day. And not quite sure how that came about, other than that was a cost savings move from the state Medicaid program. And we were able to generate kind of out of this thing that came out of nowhere, this idea and this decision that had been made. And we were able to put, providers and kind of patients and families and kids, and we got about 2,000 people riled up to both kind of testify and contact their state legislature and to really engage in this question of just how asinine this idea was and how it just wouldn't work for people to manage their conditions. And we were able to get that reversed. And it was a direct result of people's engagement. It was a policy decision made without, frankly, community input. And when the community learned about the threat that was coming in, we had a really strong response and we fixed the problem. That's a minor issue out here in one state out of 50, but it's one of the ones that I'm really proud of because the community response was just so instant and so strong, and we did actually get it changed in real time.
Do you think?
Oh, go ahead. Sorry, man.
I was just going to follow up. Do you think that policy decision that was made without community input was made out of ignorance, or do you think it yeah, ignorance, and that was
Yeah,
beneficial.
the state put an expert review panel together to look at how can we get some cost savings out of the Medicaid program. And they looked at where they were spending money, and one of the things they were spending money on was blood glucose test strips. So uh, they made a recommendation to reduce the number of test strips that they would reimburse for. I mean, it wasn't it was a cost savings exercise. And the blunt reality is that people living with type 1 diabetes, we are costs to the health insurance system. We are not savings. Um, and we are at risk when we start running cost equations on how do we save money in systems because what we do costs money.
Mhm.
Yeah, I have another Washington State example from about a decade ago. State of Washington state Medicaid program um, allowed the managed care organizations that were providing coverage to anyone in Medicaid to restrict coverage. And when I say restrict, prohibit coverage for insulin pens, which is a basic civil rights issue for kids in schools because there's certain school districts that will not allow syringes to be on campus and vials because they're concerned about illicit drug use. So we went in, DPAC, DLC, a number of volunteers, a couple of manufacturers of insulin, and sat down with the department and had a very frank conversation as to the harm that they were going to inflict on families and the harm that they were going to inflict on kids. And for the first time in the department's history, they issued a corrective notice to the managed care organizations that they had to, in fact, cover insulin pens for anyone under the age of 25, I think is what it was. It might have been 21, and women with gestational diabetes. That was a blanket directive, and the speed with which that occurred. We're talking about the notice being published in January. Early February, the department meets with the diabetes community, and a week later, the department issued the corrective action and said they would not allow this to occur. So that's a local example. Oh, can I provide examples from Medicare Part D changes to coverage of insulin pumps in the Medicare program, to yesterday's events in Indiana that had hundreds upon hundreds of people calling elected officials in Indiana saying, "Do not repeal the Safe at School Act." So there are lots and lots.
Yeah, well, what I'm hearing is that Washington is the best state to be in, I suppose.
Obviously.
Come on,
Uh,
man. California. What are you talking about, Jake? Please.
I agree. So what finally we've reached where I had to stop you on the first question, Tom, which is what is the biggest policy challenge the diabetes community is facing right now? And if someone is new to diabetes advocacy, where can their voice make the biggest impact?
It's the erosion of benefits.
100%.
It's the erosion of rights, the erosion of civil rights, plain and simple. Biggest issue facing the diabetes community. Things that we've taken for granted as being protections and things that have made our lives more affordable. I will certainly not say affordable. I will say more affordable. That's a real significant and consequential issue. And I think the most important thing that you can do is become engaged in DLC and DPAC's programming, because we're doing everything that we can to provide guidance, counsel, direction on how best to engage at the federal level and also the state level. And I encourage everyone to do that.
Could not agree more. And also, there's a couple of other questions in the Q&A that we'll get to as well. But one specific note on this: we're playing defense right now at kind of all levels of government, and that's fine. But just like Tom said, preserving the rights that we've earned is our goal. But what does it mean to preserve rights? It means access to healthcare and the cost of healthcare. Those are the two planks of everything we do. How do we make sure we have access to what we need, and how do we afford to pay for it? So right now at the federal level, let's put this in some specifics. the Republicans in the House right now are really advocating a healthcare response to the Obamacare tax credit issue. One of the things that they're working on is like we should have more health savings accounts, or we should look at incentivizing health insurance programs that create special tiers for high risk needs, meaning us, right? People who live with expensive chronic conditions. There is no way on earth these are positive developments for people who have high utilization rates for health insurance and the health system itself. But this is a political party's response to the rising cost of healthcare. And anytime we get into how do we cut things out of healthcare, it bleeds directly into access and cost for people living with chronic conditions.
Yeah, so can you describe in a concrete sense what is at stake and what could potentially change for our advocates?
Yeah, the biggest fear I have is that we no longer have a right to health insurance. And so what does that mean? The Affordable Care Act created something, basically they created a ban on using pre-existing conditions as a way to deny people the ability to get health care. So prior to the Affordable Care Act, if you were an individual living with diabetes and you were not coming to buy health insurance through a large group, you could be denied access to that market simply because you had a pre-existing condition. That fundamentally changed in 2010 when the Affordable Care Act was enacted into law. And that created the rest of the access to things like CGMs and pumps and everything else that we're doing through the insurance program stems from that singular difference that was done as a part of the Affordable Care Act. So the more that we unwind the ACA, the more that we put at risk the rights for us to get access to these programs. And I'm not talking about cost or subsidized cost or anything like that, just plain and simple access.
Yeah, and all the solutions that are generally being proposed take more money out of the pocket of somebody with diabetes. Let's use the insulin issue as an example. You've got it, depending upon the state, depending upon the Medicare program, variety of other issues, but it's generally accepted that it's a $30 or $35 copay per insulin per 30 days. Okay. It used to be $5 as a copay or $10 as a copay. So now this narrative has kind of taken hold that, well, it's affordable. I would argue that it's more affordable for a number of people, but it's less affordable for a number of people as well. And if we think that $30 to $35 a month for one insulin, or some people require 2 or 3, if we think that that's made things affordable, oh, it's not. And what do we do about syringes and needles and insulin pumps and all of these other things that people could eventually say, well, $100 a month is affordable for that, or $100 a month for glucose sensors, that's affordable. The more we take out of the health insurance coverage dynamic,
Yeah.
and make it a cash pay exercise for the person with diabetes, the more money that you will experience being taken out of your pocket. And you're also going to see, as we're already seeing it, fewer and fewer health professionals accepting health insurance, which means you're going to have to pay, we're going to have to pay in order to see doctors a premium price to get our care. I don't think that that is a road to success from a diabetes policy point of view. And I see the narrative around in the GLP-1 space that, oh gosh, $499 a month, that's affordable. No, it's not. No, it's not. Also, I should remind everybody that's $499 for 28 days or $399 for 28 days. Or if you're taking the oral form when you start off, it's $149 for 28 days. That's not a month. It's 28 days. So I keep seeing an erosion of financial sanity in that's occurring in all of these policy moves. And it brings me concern. Am I happy that there are affordability programs? Without a doubt. But fundamentally, the system, the health insurance system, has to in some way be designed so that it benefits people with diabetes as opposed to harming them. And I see a lot of these policy initiatives harming people right now.
And this is why Tom just proved my point that Washington State is better than California, because we are closer to Canada.
Yes, you are.
Hey, a couple of quick questions in the chat. First of all, if everybody can see those questions, there's some great ones in there. Mike, I appreciate your comments about the co-chair of the Diabetes Caucus. That's exactly right. Like, these are the types of challenges that we have with the scorecard. Melanie, I don't know where the right source of data is, but I also don't know that data is like the role. Data is the responsibility of the diabetes organizations that are in the advocacy space. It's important that when DPAC lobbies that we have solid data in place. But when individuals are a part of that effort, actually stories make a big difference. And it's less important that you know the aggregate data of about, how many people are on Medicare and what does it cost, than you do, here is my story about living with diabetes in this situation. And this is why I want you to care about it and why I want you to fix this problem. Individual stories married with large diabetes advocacy groups doing the data exercise is the secret ingredient for how to get stuff done.
Okay, so our next, well, actually, building off that, I wanted to ask, for someone who wants to get involved right now, where would their voice make an impact and how could they begin?
Getting info on what's happening or what's going on. I'm sorry, Amanda, what's the
For someone who
data?
wants to, that too, for someone who wants to get started as an advocate.
Well, Tom and I and Amanda happen to be involved with this little organization called DPAC, the Diabetes Patient Advocacy Coalition. And if those of you who aren't familiar with it, we'd encourage you to go to diabetespact.org and read about what we do. You can also sign up to join kind of the advocacy team at that point. And for those people who want to go through some training and be more involved, we have something called a champion corps. And these are our fierce advocates at every state and in DC that engage in these policy issues. There's also weekly meetings of the Champion Corps, not weekly, excuse me, monthly meetings via Zoom and via kind of online systems. Amanda runs that, so you get to see a lot more of her, which those of you who don't know her snarky tone of humor will grow to love and appreciate. But DPAC's not alone. The Type 1 International, American Diabetes Association, JDRF, Breakthrough T1D. There's a lot of organizations that are in this space. DPAC is doing a freaking great job of figuring out when are the fights, it's the timing of the fights, and then mobilizing the people around those fights. And one of the things that I really love about being associated with DPAC is that we work at both the state and the federal level. So whether it's in Indiana yesterday or whether it's in DC tomorrow, kind of DPAC has the ability to scale and work in both places.
Yeah, and we are a small but nimble team, so we have that flexibility. Like, for example, yesterday I created an email campaign and infographics about Indiana and then got a notification that it already passed. So that kind of stuff happens all the time. Also, thank you, Jake, for plugging DPAC. It would have sounded a little less genuine coming from me or Tom because we work here.
I also, this is gonna make me sound like an old dude, and I apologize for sounding like an old dude.
You could never.
But
things are what they are, Tom.
Back in the good old days when Jake and I started in government affairs, there were these things called newspapers, hard copies that we could actually read on a daily basis. And we worked for legislators who read these things on a daily basis. It's frustrating that that method of education is as restricted as it is right now, which I think is creating some unique problems and challenges for people to be aware of what is occurring. These algorithms and social media are just inundating people with things that they want to see or they believe is the reality versus what is the reality, which leads me to the best thing that you can do as an advocate is to become extremely educated about the issues that you care about. And and really get engaged from there, because you owe it to yourself to have an understanding of what's occurring out there.
Yeah, I don't know, Tom, if you saw, but Jake called you a baby boomer in the chat. Next question. What's one misconception you see advocates or the public have about how policy change actually happens?
There's a saying which I don't like to be a guy who uses sayings, but nevertheless, it says that change always happens much too slowly until the precise moment when it happens much too fast. And like I feel like that's diabetes advocacy, right? Insulin pricing is what we were on and are still on for so long, but that's been like the clarion call of the diabetes community for so long. And then we couldn't get it done. We couldn't get it done. And then it happened in the Medicare program. We still have to extend that to other places as well. But that is what working in policy is like. You spend a lot of time pushing that rock up the hill, and then one day you get there. And I think that that is what is you asked like what is not known kind of for people in this space, but just that work and that push and that even when you don't get it done, that is actually laying the foundation for it to happen in the future. And like we need so many people involved in that fight. We really do. And even if it doesn't happen fast, we still need your help.
Yeah, these some people think that these events occur and your opportunities present themselves immediately. Yes, sometimes that does occur, but the bulk of the change that I've seen affecting people with diabetes, meaning it's an enhancement of civil rights or an enhancement of benefit coverage, those are battles that occur over years, not immediately. Which leads me back to the erosion can happen very quickly, but the opportunity and the fight that's necessary to make progress takes a long time.
Yeah, we often, when I meet people on the ground at conferences and at events, ask us, and I also asked you two just now, what we can do immediately. But this game that we play it's more so a waiting game, and it's sad because we have to we're really enthusiastic and we want to do everything all the time, but it really has to be um, you have to be patient, and I struggle with that too. So are there emerging legislative or regulatory issues that people with diabetes should be paying closer attention to right now? Although I feel like you've already kind of addressed this.
Yeah, I mean, once again, I mean, I think I'm repeating myself a little bit, but we're playing defense, and I think that the things that keep me up at night in diabetes policy are not what we can get done in the future, but what's coming to us that we have to protect against. And I think for the most part, what I am worried about is the state response to $1 trillion in Medicaid cuts. And again, California is going to do it different than Nevada. It's going to do it different than New Mexico. But like how do states respond to the lack of funding that's coming in to take care of people that don't have a lot of other options available to them to get health insurance? And that is the threat, that we don't know exactly how it's going to manifest in every state, and it's going to happen differently in different states. So as all of us kind of can stay engaged in these processes, that's the thing where we want people to flag when they hear things coming down, that we need to know. And we need to know where these threats are coming from rather than just this unknown monster in the woods. Like, where are the specific threats coming through specific states with regard to access and cost?
Yes, and I just addressed a question in the chat. In Oklahoma, what do I need to work on here? DPAC also has a state handbook that shows progress on various policies by state. It's diabetespac.org/handbook, and I just put that in the chat as well. Okay, my last question, I know we're a bit over time, but if you could time travel one policy insight back to advocates 20 years ago, what would it be?
Back to one policy insight 20 years ago. Can you give me just a little bit more to work with there, Amanda?
I got one. I got one.
Yeah.
20 years ago, we thought that once we established some protections, that like we'd have this, it would be okay. Once we got our foot in the door and some of these things would be okay. And I think what we didn't know 20 years ago, and I wish that we did, was how important it was to have statutory protections for people living with, and whether we're talking about discrimination issues or access issues, to get that shit in writing in the law, and not wait for it to be threatened due to different interpretations at either the state or the federal level. I think that we sometimes that approach, it was the right call at the time because we got it done. But going back, I wish we'd had stronger legislative language.
And perhaps stronger legislative leaders. There's some things that happen in Medicare Part D and in Obamacare that all hinged on one senator at a time. One person wanted this, another person wanted that.
Yeah.
Another person established a ceiling that the Medicare Part D drug benefit could cost no more than $500 billion and over a period of 5 or 10 years, and created these crazy deductible and copay schemes as a result of it. It really speaks to the need back then. I'm not sure that it applies now, but back then we really needed to be much more nimble on our feet, I think, which possibly could have lended itself to now being more nimble on our feet. But I just don't know. I'm not sure that it would have panned out any differently.
Well, on that note,
Yeah, no, I have one more pitch. For those of you, we don't have any visibility from where Tom and I are looking at the screen. We don't have any visibility into who's here or where you're from or kind of what your connection is to advocacy in your own lives. Let me just, if you're doing something today, let me just thank you. I live with type 1 diabetes. My daughter has type 1 diabetes. Thank you. Thank you for being involved and creating like whatever you're doing. Thank you. And if you're not doing anything, let me give you an open-armed invitation to learn a little bit more. Sign up for the DPAC newsletter. Like, attend a webinar, an additional webinar or two, but just like try to take a step forward. We have some fights ahead of us to preserve what we've earned and to try to make the case for additional protections moving forward. We do that when there's a lot of us. I mean, the math is pretty easy on this. The more of us that raise our voices, the better our chances of success. It's not rocket science. It's pretty easy, actually, at the end of the day. DPAC is an instrument to lift those voices in a strategic and collaborative and effective way. And there's an open invite for y'all to join us. Please do.
And if you want to go further, you want to go to a town hall meeting, you want to get that appointment with those elected officials, we're here to help you do that. And we have a lot of experience doing these things, and we can help you craft your message, help you deliver that message. And you haven't lived until you've been into a town hall with Jake Johnston or Tom Boyer to help you figure out how to do it. We're happy to help.
That would have sounded better coming from me, but that's all right. Thank you guys for joining us on our webinar today. I was about to ask you if you had any final comments, but it sounded like you helped yourself to that. So thank you for joining us.
Sign of a good lobbyist there, Amanda.
You're right. That's just testament to how much your life will change.
Hey, Amanda, you live with type 1 diabetes and you work for DPAC. Do you have any closing comments for us?
Well, I don't want to be the person who says join DPAC, but I will say it is like the best way to stay abreast of what's going on, especially on our social media, because that is the avenue that we update with communications the most often. If you sign up to be a champion, you will get monthly updates on what's going on in policy. We are here as a resource. You can contact us at our email. You can contact us on social media. We're always here answering questions. We can even connect you to Tom and Jake if they allow it. But yeah, so thank you for joining us, and let us know if you want to see more content like this. We're here to serve you. So if you want to see more of this, I can rope Tom and Jake in again, and we can do this again.
Thanks,
Wow, we have
everybody.
people in the chat telling other people to join DPAD. Oh my gosh. Thank you so much.
Thanks, everyone.
Thanks for having lunch with us.
Thank you.
Everybody take care.
Bye.